I get to welcome two incredible people who happen to be real life friends and are going to speak together. So the first is a licensed clinical social worker with over 30 years of experience in behavioral health. She's a consultant all across the Pacific Northwest in facilitating the adoption of full spectrum behavioral health integration programs. She is the co-founder of Synergy Health Consulting, which provides such consulting. And she has spent much of the last decades working with the Jackson Care Connect and Care Oregon, supporting primary care practices. She's got a very long history of developing health system support. So we're really excited that she is here. And that, of course, is Laura Heesacker, LCSW. And then joining her is a certified peer support specialist. Hi, Laura. Nice to see you. Let me set up Michelle first real quick, and then I'll get out of your way. A certified peer support specialist who herself has lived with chronic pain since 2003. She attended the Mayo Clinic's Pain Rehabilitation Clinic in 2012, and through that program, she was able to taper off of high-dose opioids and benzodiazepines. She became an Oregon Pain Guidance Steering Committee member and worked on the Southern Oregon Pain Conference planning team, and then later became a certified peer support specialist. She began and ran the pain support group in Jackson County, and she also was a participant in the media campaign that won an Emmy, which is pretty exciting that she's here on camera with us, because, I mean, if she's got an Emmy, well, then we want her on camera. So that, of course, is Michelle Marikos. Michelle, I'm going to invite you up. And then Laura and Michelle. Oh, see, you look amazing. You look like you need an Emmy. Before I turn this over fully, we have to be in compliance, because that's what it's all about. So I have to show your disclosures. Yes, it says won an Emmy right there. No, it doesn't say that. So thank you, Michelle, Laura. And I'm going to step off stage, but I'm right here. So welcome. Hi. Thank you.
Thank you, Ian.
Thank you so much, Ian. It is such a privilege to be here with all of you today. Before we start, we wanted to talk about our slide presentation in a way, because we pared it down quite a bit for today's time slot. And we just wanted to let you know that all of the slides are available to you at the end of the presentation through the resources. So if you, so the parts that we cut out were the information about the research components. So this is a research-based talk, but we just cut those components out so that we would have time to kind of get into the nitty-gritty about difficult conversations and compassion-based conversations with providers and patients. So we really want to thank you so much for making the decision to come with us and go through our journey today about how to have these difficult conversations. We also want to mention that we're going to be doing quite a bit of work in the chat box. So we really want you to use the chat box as much as possible, and we will be looking at the comments and kind of going through the comments as we do our presentation. So before we start the presentation, I'm going to ask that whoever's in the room today, please use the chat box and put in what disciplinary team you're on. If you're a pharmaceutical rep, if you're a provider in a pain clinic, just tell us who you are in the comments so that we can kind of base our discussion and questions around that. Laura, do you have anything else to add before we start?
No, I was just figuring out how to get back to being able to see the comments. I think I have. Are you seeing the comments?
I am seeing the comments. I have everyone's applause, and then nobody has made any comments yet.
Okay.
So just a reminder, please put in your disciplinary team, and yes, we will move on to our slide presentation. So beginning of the slide. So this is Conversations as Medicine, Compassion-Based Difficult Conversations. So next slide. As Ian wonderfully introduced us, Laura and I have known each other for many years now. I actually still live with chronic pain, And this is a very close to my heart subject about difficult conversations, because I've gone through so many difficult conversations, especially around tapering and opioids. So we will get into that more. I'm going to let Laura introduce herself a little bit more.
Sure. Good afternoon, everyone. Thank you so much for inviting Michelle and I back. And as Ian said, we are real life friends. And of course, we were so excited about coming in person. And we just want to say thank you for inviting us back. As Ian said, I've been at this for a while, and I just before this counted up my years. I started 33 years ago working in an interdisciplinary pain clinic in Portland, which was essentially a very similar clinic to the one that Michelle went to at Mayo. And I was a biofeedback technician right out of my bachelor's degree. And interesting, just sort of coming full circle, that was a time in history when people were basically getting kicked off workers' compensation and often on quite a few opioids. And so we were working with a lot of people tapering in that clinic from a multidisciplinary standpoint. So it's really nice to sort of be back in that place. We had I don't know, 20 years or so of really trying to rely on medications for things that we probably shouldn't have been trying to rely on. Not probably, we shouldn't have been. So the thing that I did after working in that pain clinic was I went to work for primary care clinics, and probably spent about 15 or 20 years alongside team members, primary care providers, and other team members, having difficult conversations, talking with people, and often about addiction, about mental health, about pain medication. And so what we've done, Michelle and I, is really just kind of put that all together and coming up with some things that we think maybe can be useful to all of you. And as Michelle said, we are going to be asking you to do a lot of things in the chat box. It's the end of the day, and so we want to get as much interaction as possible. And Michelle and I have also found that there's so much wisdom in the room when we come and talk about this topic. So we really want to enlist all of you to support this. Michelle.
Next slide. So we don't have any disclosures. Many thanks for inviting us and having us here today. We're so happy to be here. Thank you so much for attending again. Next slide. So our objectives today is really creating an understanding about what a difficult conversation is and how this process is a parallel process between providers and patients. So we're going to go into a concept called two sides of the same coin. And it really is two sides of the same coin. What providers feel, what patients feel, it's very similar. So we're going to also put that into use through our research. Our research, we found 5 foundational components to difficult conversations for providers and for patients. So this is really going to set you up on a successful path to have difficult conversations, as difficult as they may be. So next slide. And so I'm going to have you click through to bring up all of our little points. Thank you. So today, we really want to go in with realistic expectations about difficult conversations. This has been such a hard process for me to get into, because as a person living with chronic pain, I immediately knew that the medical system wasn't built for people living with chronic illnesses, chronic conditions, and chronic pain. That's not what the medical system was built to do. And once you're inside the medical system and inside the kind of tornado that starts through that, you start figuring it out. And it's so hard to sit down with providers and have these conversations as a patient over and over and over again, that really we want to applaud providers and anyone working with patients, living with pain, living on opioids, that these conversations are difficult, again, because the population is difficult. Living with chronic conditions and chronic illness and chronic pain, it's difficult to begin with. So we want to applaud you for that. And we also, there's a disclaimer too, that through our kind of talk today, that this isn't going to be the answer. It's not going to be have this difficult conversation. It's going to solve everything. Here are the steps 1, 2, 3. This is a long process. This is an arduous process. But we have to start having these conversations to be able to get our patients to be able to move through their pain and move through and be successful where they haven't been successful. And we know that patients can be successful with living with chronic pain because there are so many people doing it. So we want to be able to have this process of having the patients be seen. So many patients aren't feeling like they're being seen, and having these conversations really gives the patient, but also gives the provider a chance for the provider to be seen, but a chance for the patient to be seen too. Laura, do you have anything to add?
Nope, I don't think so. Yep, I think we just keep.
Okay. Next slide. So we're going to go into our first chat box conversation about how do you define a conversation, a difficult conversation? What does a difficult conversation to you look like? What are the components? What are the emotions that get brought up in difficult conversations? We want to have a little bit of conversation in the chat box so that we really can, understand where you're coming from. So immediately, Ian has said it's energy sucking. It is. And from the provider, from the patient point of view, living with pain is also energy sucking. So that was a perfect add, Ian. Thank you so much.
And I think we just want to add that, this talk is about pain, but we all have difficult conversations all the time. So feel free to be pulling on other parts of your life where you may be having difficult conversations. I have 2 young adults, young adults. And so I definitely can think of a lot of spaces where I have had difficult conversations or need to have difficult conversations. So we appreciate, yes, Nora says intimidating. And Paul's describing some of the specific types of patients where high dose or where difficult conversations happen. The being a new provider with a patient who's presenting, patients who are maybe not being in compliant, places where we are anticipating that there's conflict. Mark says power struggle. Absolutely. Talk about teenagers, right? I feel that one. Yeah, one that's not going to be received well by both participants. Yeah, boy, emotions and stakes are high. Take it away, Michelle. There you go. There's your lead in.
Yes, very good. Next slide. So one that elicits, next slide, one more. One that elicits uncomfortable emotions with both parties. So this is everything that is described in our chat box is this. It is uncomfortable. It is excruciating. It's excruciating for the provider and it's excruciating for the patient. And we are going to, by the end of our discussion today, we are going to bring you to a different place and hopefully make it less excruciating. It's always going to be hard. There's no easy way about it. And this population, myself included, we're just a difficult population because what we have to live with. So, but we are going to bring you to a different place today and hopefully give you some tools that will make it a little bit easier in the end. Next slide. Laura,
right.
Take it away.
Yeah. Hey, 10 points for anyone who could tell us the name of the show that little clip came from. Be a prize at the end. Oh, come on. She was a lawyer. Nope. I guess give people a few more minutes. I'll tell you if it doesn't come up. So I was sort of just getting oriented when I first came on, and so there was a couple things I wanted to say. It's so great to be. It's such an honor to be here with all of you, and so many of the presenters. Michelle and I have been around the state, around the Pacific Northwest with, and so it just feels like old friends week or old home week. So again, just so lovely to be here. I think Dr. Murphy's talk could not have set us up any better. Yeah, Allie McBeal, there you go, Nora. That's it. Yep, 10 points for you. So thank you, Dr. Murphy. And I think a lot of what Michelle and I are going to be doing this afternoon is really just underscoring a lot of what she said and so much of what so many other people have said as well. So I love that it's happening at the end, and we'll just be sort of emphasizing a lot of things that were already said. So as Michelle mentioned, we spend a lot of time thinking about this topic. We've done a lot of presenting on this topic. I think every time we present, it changes a little bit. Some of you have heard us talk about this, and we get together usually around my kitchen table, and we really sort of think about what could be helpful and what have we learned. And so one day we were talking about sort of this idea about this sort of the patient and family perspective, and the provider and the team perspective. And so we came up with this idea that so much of what's going on, and others have referenced it today, especially Dr. Murphy in her talk, is what we would call sort of this parallel process. And that there's a lot of things that are happening on both sides of the coin that are very similar. And when we can go into these conversations and these situations, it can be helpful to really be thinking about that you're having often a very similar experience as your patient and the family. Next slide. So we came up with these 5 foundational components. I will tell you also at the end, we have some resources for difficult conversation cards. At one time, we did a whole bunch of difficult conversation cards that you could print out and put in your pocket. And those are on the OPG website. We'll give you the reference for that. But we were sort of thinking about sort of more general components that we could share. And the 5 components, which we're going to step into, and we're going to sort of do this ping pong back and forth. And I'm going to talk a little bit about, some of what I've learned from being on a medical team from way back and throughout the years. Sort of watching how when providers and team members were doing pretty well with these conversations, maybe getting the results that they were hoping for, and some of the different things that they were paying attention to and maybe using in those conversations. And so I'll just list them: relationship as a resource, having realistic expectations, making sure you're really understanding around values and values identification. Again, you heard that earlier today. This idea about what you believe really matters, and the confidence that you have. And I will just tell this story. I met Michelle when she came to present at one of our, she's smiling there. She knows I'm going to tell the story. At our OPG meeting, which was filled with mostly medical providers. This is maybe 10 plus years ago. And she got up and told her story, and so brave. I mean, oh my goodness. And anyway, so she ends her talk and she says to everyone, and she says, we know when you don't believe in what it is that you're asking us to do or that you're recommending. And we know when you don't have confidence in us. Maybe it's around being able to be successfully tapered or whatever. And, it was just sort of this plea for her. It's like, find your belief in us, find your confidence in yourself and in this process, and it's going to go so much better. So anyway, we can go back to the slides, but I knew that I was Michelle was just going to be my friend for the rest of my life, and we were going to be presenting together forevermore. And finally, probably our favorite, we saved our favorite for the last, and probably if we had to pick, it would be the most important one. And that's that willingness to feel uncomfortable. And you're going to hear Michelle really talk about on the patient and family side, but on the provider and team side, that willingness to feel uncomfortable and leaning into that. And if we were in person, I would be handing out Chinese finger traps. For those of you that know what this is. And, this idea that the more you try to pull away from what is uncomfortable, the harder the situation gets. And it's really the leaning in that really allows somewhat of a release. Next slide. So the first one, which is relationship as a resource, and Michelle's already mentioned that, it's this idea that of course, this is not going to work so well if you don't know the patient, and that if somebody is new to you, you may not have the relationship established. But oftentimes, you do know these patients. And so when you can, really lean in on that relationship, and you might say something like, this is a work in progress, right? And right out of the gate say, like, nothing has to change today. Again, Paul mentioned earlier today that this is you're in this for the long run. Like, you get somebody on a high dose opioid, maybe definitely oftentimes the first thing you want to do is just broach the subject, right? We talked about that Bravo protocol, and I was a part of that, and that B of Bravo is broaching the topic and being, able to say to somebody, the first thing you might say is, we're not going to make any changes today. And because to say anything else, honestly, oftentimes, and I've watched it in rooms with the team, with providers, the patient's frontal lobes just go offline. And if they don't hear anything else you say, but often you can keep them with you if you say something like, nothing's going to change today. I'm going to stay by your side. We can go slow. And these are reassuring, again, reinforcing that safety. And Nora talked earlier today about so many of our patients that are struggling with high dose opioids or struggling with tapers have histories of trauma. And the most important thing that you're going to be able to do is establish a sense of safety. Michelle, next slide.
So that is a good segue into something I want to mention also. In the very beginning, when I was talking about, why are these difficult conversations so difficult? It really is a safety mechanism for patients, because once they're in the medical system, they start feeling unsafe. And so, kind of piggybacking on what Laura just said, that, within this relationship process with your patients, that it is so important to make your patients feel safe, because they've already become traumatized within the medical system without even seeing you. Once they're in the medical system, living with their chronic condition, living with their chronic pain, they are going to be traumatized just by that in itself. So I just wanted to say that side note. I know that was an important piece that I missed earlier. Really, the relationship as a resource for the patient side, it's about bringing in that support system for the patients, whether it's a peer support specialist, whether it's a friend, whether it's their support system within their families, really encouraging your patients to leverage that relationship and bring those people into these difficult conversations. One, because their family is going to see them in a very different light than you see them. And they're also, the husband, the wife, the whoever they bring in is going to have such a different perspective, but they're also going to be able to give you nuggets of information that is going to help you along the process of how to motivate your patients in a different way. So, and also being able to ask them, what would you say about patient A struggle with their pain and struggle with opioids? What are they doing every day in their everyday lives with opioids? And, how can we change this to be in a more positive direction with pain and with opioids, or with tapering, or whatever the difficult conversation is about? Next slide.
All right. Yeah. So number 2, having realistic expectations. And Paul, again, I just want to appreciate the chat. We're really loving that, really identifying the 3 big difficult conversations. So thank you for listing that, and Ian for noticing the symbolism of our slides around collaboration. So one of the most important things is really this idea of boundaries. And I'm a huge Brene Brown fan. You probably could guess. And one of the things that she says is that um, that you really that you to not have boundaries is not compassionate, right? And so that this idea that, and she talks about this, the big question, I couldn't figure out how to post this, but I'll send it a little bit later in the chat. There's a great 5-minute video of her talking about this boundaries and compassion. But she makes this statement: what boundaries do I need to have in place in order to maintain my integrity and make the most generous assumption about you? And I love that, because it's really like, and again, that idea about boundaries definition, sort of what's okay and what's not okay. And so, this idea that, a patient might leave upset because you've set a boundary, right? And a boundary might be something like saying, prescribing more medication is something that I am not able to do. It's not safe, and I'm not able to do it. And of course, one of the things we also know about setting boundaries is to say first what it is we can do, right? And so you can always say, I'm going to continue being your doctor as long as you'll uh, allow me, and I'm going to continue on this path with you. And these are some of the ways that you can set those boundaries. And then, you can agree to disagree, right, with your patient. Your patient, I think it was Dr. Murphy earlier said, patients are really like super excited to go see a psychologist or a physical therapist or to, whatever it is. And that's okay, because again, remembering that idea about what you believe and how confident you are about what it is that you're sending them to or asking them to engage with. Again, remembering relationship as a resource. Sometimes it's like, could you do this for me? I know you don't believe in it. I believe in it. And I've really seen people do better. So next slide.
One slide back, I think. There we go. Okay, so realistic expectations for the patient is critically important when you're having difficult conversations, especially because patients have expectations that, one, they're not going to be in pain anymore, and two, that opioids are always the answer. And so when we, I love this slide and this handout for every patient, being able to look at the actual real numbers and what opioids can do and what opioids cannot do. And so, throughout my own journey, I never saw any of these numbers. I was never presented with opioids can only do this small amount, and all these other things can really make up, the other part of being a successful person living with pain. And so, I always encourage providers to go over, the different expectations of what patients are feeling and what they're going into. Of, am I expecting the opioids to do it all and I'm not going to do anything? Am I expecting to come out of this office with a cure? And so having those conversations and peppering, kind of this evidence-based information about, we don't have a cure for chronic pain, and that, opioids are not always the answer. So I just love this information. Laura?
Yeah, next slide. And Eric was just saying he likes that chart as well. Boy, that has been around forever. I wonder if Dr. Sullivan was actually a part of that. I didn't see his name on it, but that came out of University of Washington, and we've been carrying that around, laminating it, giving it out forever. So this next one is about values, and I want to just take a minute. Again, others have talked about values today. Values on the part of the provider and the medical team. And I would just like to invite everybody, if you're able, to just stand up, because what we're going to do is we're just going to take a minute. We're going to ground ourselves in our values and really feel that in your body, what it feels like to say, in terms of this work and in terms of like this difficult conversation, what is the value that it is in the service of? And so maybe it's in the service of practicing safe medicine. Maybe it's in the service of being in alignment with evidence-based care. Maybe it's in, whatever it is. And if people want to put in the chat box, what are these difficult conversations in the service of? And it can be a difficult conversation outside of this particular area. Again, thinking about teenagers. It's often about safety. But want to just invite you to just stand in your values, right? And think about values are those things that live out on the horizon. It's the things that we orient our compass towards. We never really meet it, right? If we're going towards true north, right? We just move in that direction, and then we readjust. And it's a constant process of us. I love the term reorienteering, right? This sort of mountaineering term that we're just sort of looking in the direction of the horizon of our value and readjusting. So, you may find yourself getting upset with a patient, or you may find yourself just feeling down and out, or maybe you made a snarky response, or whatever it is, you can reorient towards your value. And then committed action is really about what is it that you want to do in this moment, right? And so maybe it sounds something like this statement to yourself around, in the honor of my value to align with best practice medicine, I will broach the topic, right, of whatever it is, X. And I will commit to making one microdose change, right? Maybe you're just committing to broaching the topic with a patient that maybe is going to be very defensive, aka ambivalent, right? And scared. So this idea of walking in your values, standing in your values, in that being what these difficult conversations are in service of. Michelle.
And so in the chat box, Nora has said, connecting to and motivating the patient to know how much they can change themselves. And that is what this is for the patients, of what is important to you and why is life worth living? What are the things that you have lost and you want to get back to? What are the motivating factors? For myself, it was the fact that I had pretty much lost my whole life. Of wasn't working, wasn't leaving bed, wasn't doing anything. So I picked one thing. Okay, I wanted to return back to work. And at the time, I still do. But at the time, I owned an orchard, a fig orchard, and I wanted to be able to work in the dirt again. So that was my motivating factor of like, I wanted to be able to just be outside, be able to work in my orchard and do that thing. And when I was asked about my values, I was able to give an answer, and patients will be able to give answers because they know how much they've lost and what they want to be able to have returned to their lives. And again, making patients can make the change in that service of the values. That's really what this is, identifying those and how to get back to them. Next slide. Laura?
Yeah, and I just want to say, like, on that piece, it can be hard because for so many patients living with chronic pain, oftentimes they may not be able to tell you what their values are, right? But they may be able to tell you what their values used to be or what used to be important. And so we can start wherever people start is where we start. And even just getting people, back in that space of thinking and talking about that. I'm appreciating the people putting in their values around what this is in the service of. I'm going to make up a little time because I feel like I've covered this topic around confidence, having confidence in your patients that they can live a full and meaningful life without invasive, unsafe, or ineffective pain treatments. And today has been such a great example of, this idea that we know so much more now about contemporary pain science, and really understanding what the research says. And then really, early on, we would say to people, if you don't really believe it, go talk to somebody that has experienced watching people get their life back, and borrow their confidence and use that in conversations with patients. And pretty soon, you'll have your own. Go ahead, Michelle.
I just want to kind of go back to the story that you had told earlier about when we first met, of beliefs and confidence was the thing that always stood out in my mind. And it actually surprised me to the nth degree when we actually first put together this presentation and we were doing the research-based part of it and the JAMA articles, and that the 5 components were in the JAMA articles, and that belief and confidence was one of those things. And we had been talking about it for many years before, that was, such a important, really a pylon to hold up the whole conversation of beliefs and confidence. So we'll make up some time. Next slide. So our 5th and very important component is really willingness to be uncomfortable. I just want you to look at this slide for a second, because this is willingness to be uncomfortable. When all patients fill out this, body map, this is what willingness to be uncomfortable looks like. This is the thing that we are living, feeling, breathing every day. And for patients, we don't have a choice to really feel willing to be uncomfortable. This is it. We're living it. So for the provider, to be able to look at this and obviously feel very uncomfortable themselves, of like, oh man, this person really has a lot of things going on. Where am I even going to start? So it's this imagery of willingness to be uncomfortable, and what does that mean? Laura, do you have anything else to add?
No, I think this was really our setup for our next chat box activity. So
yes, it is. So I'm going to go to the next slide. And so in that imagery, when we look at that imagery on that previous slide, it's really, what are some of the emotions experienced before, during, and after difficult conversations, whether the difficult conversation was with a patient or on a personal level, was it with your husband, was it with whoever? What does that experience look like? And what brings up those emotions? What are the emotions that are brought up? And we want you to put those in the comments in the chat box so we can discuss that a little bit and kind of go further into detail about that.
Yeah, and as people are putting that in, I just want to comment again, appreciating the chat box, appreciating Dr. Coelho, really talking about how difficult conversations have diminished due to having there be fewer patients in Oregon on high-dose opioids. So definitely that is true. And yet, my sense is there's still a lot of difficult conversations out there to be had. So this idea, one of the things that we say in psychology is to name it is to tame it, right? And so this idea that we can label those emotions within ourselves as care team members about, going into a room to have this conversation can be really powerful to name that. And so I'm appreciating what's coming in: overwhelm, helplessness, hopelessness, putting armor in place. I love that. Pity, sorrow, relief. And I don't know, Michelle, as a person who's went through this process, how are these feeling for you?
Anger, frustration. Sometimes I feel anger.
Yeah, and all, I love that Rumi poem, The Guest House. If you haven't seen it, look it up. All are welcome here. All are guests, right? And welcome them all in because they're all important. And again, I think being able to name it goes so far, even if it's just silently to yourself as your hand is on that door, or others have said today, just getting support from your team. I cut my teeth on team-based care, multidisciplinary team. We had a PT, an OT, a voc specialist, a psychologist, doctors. I mean, nurses. I that's right out of school. That's what I went into. And I don't know. I've always been a person who works on a team because I don't know how to do it any other way. Yeah, go ahead.
Answers in here: empathy, compassion, understanding, frustration, understanding the patient value could go against your values. Oh, very good, Barry. That is a very good discussion topic.
Yeah, definitely. We call that a values conflict, right? Yeah, very real. And, respect. It's their story, not mine. Nice, Cindy. Yeah, boy, that's powerful. That's a great thing to remember, And in the face of a lot of suffering and, a lot of patients that I've sat with, there is a wanting often for it to become your struggle, right? And I think we talk about burnout, we talk about well-being as healthcare providers, that idea that we can get I love the term. Oh gosh, forgetting what the term is that I love. That's hilarious. But yeah, just being able to compassionate detachment, right? This idea that we can sit with somebody who's in this intense state of pain and suffering and have compassion for them, and yet remain compassionately detached for our own health and well-being. So I love that, remembering that it's their story and not mine. You want to go to the next one, Michelle?
Yeah. Next slide. So really, again, this is, the difficult conversation. It threatens our sense of competence as healers. It triggers negative emotions such as anxiety, impatience, anger, just all the things that we went over in the chat box. Emotions run high, stakes run high for the patients and for the providers. Clashing of needs and desires, especially with tapering of opioids or benzodiazepines, and really dysregulation. It is, we have gotten so good about learning about central sensitization, but really with patients that have central sensitization, even entering into a difficult conversation deregulates them. So it is that thing of being able to recognize, before I even have this conversation, how do we start so that I'm not, again, as a provider, I'm not having deregulation and they're not having deregulation. And then we're going to go into another chat box question too. So next slide. So in your practice, what are some things that you have found useful in having successful, difficult conversations? So these are the things of, is it the team-based care approach? Is it having a peer support specialist in the room? Is it having a family member in the room with the patient? What are the things, and what are the things for yourself? Are you taking a few minutes before you enter the room to calm yourself down, to kind of get yourself regulated in those ways? What are the things that you've found to be successful or that you've heard other people use that have been successful?
And Billy Reed did such a nice cue up for us in the chat box, taking a deep breath. Love that. So we'd love to hear from others again. In this talk, the wisdom is in the room, and we've learned some of the best things that we share by people sharing with us. If we were in person, we'd be having people stand up and share it, and going around the room, writing it down on the walls, the good old days. The ability to anticipate a difficult conversation by use of the PDMP and the PEG. Yeah, knowing what's ahead, right? Being able to use tools to know what's ahead. If you know somebody is having a lot of pain catastrophizing or a lot of trauma, right? And how much interruption pain is having in their life. These can be really helpful. Listening, being attentive. Yeah, I was working with a client, and I see clients as well. And one of the clients I was working with last week, she went to see her doctor about getting off of a psychotropic medication. And she said to me, my doctor doesn't see me. And it was just this really powerful and sad moment. And I think oftentimes it feels like we have to spend a lot of time to see patients. And I really think it doesn't necessarily take a long time to really see our patients. And it can really go a long way in terms of that collaborative relationship. Mark writes, Paul's comment helps mitigate being ambushed or emotionally hijacked. That's lovely. Yeah. Mark. Our early slide, our introduction slide, was Michelle and I standing in front of the Pain Resiliency Clinic in Southern Oregon like 8 years ago, which Mark was a part of that. So I wanted to shout out to Mark on that. It's lovely to have you here. A lot of people talking about being prepared, not taking it personally. Boy, I love the 4 agreements, right? That reminds me of the 4 agreements, not taking it personal. So powerful. Buprenorphine helping as an alternative for harm reduction rather than taking something away. Love that. Yeah, lots of great comments. Next slide, should we move on?
Yes, please.
Yeah, thank you everyone. So appreciating the chatting. So I think again, sort of on this, so much great information in the chat, and I'll just share a couple of other things that that providers and team members have shared with me in terms of sort of this willingness to feel uncomfortable or leaning in. And I worked with a provider, and some of you may know her, but she would, before she would go into a room, she would hold her hand over her heart and she would say, "May I have this conversation with compassion and grace." Right? Sort of like a mantra that she would carry into the room with her. Other things that if you have the ability to dim the lights, right? Sometimes when we're in these medical settings, the lighting can be ridiculously bright. And for some of our patients, especially patients who've experienced trauma, that can be really hard. So maybe you have the ability to turn off one of the light switches and have it be a little bit dimmer. How you sit next to a patient, right? Do you sit across from the patient? You know, sort of almost can almost be confrontational just in the way we sit, versus can you pull a chair up beside the patient? And saw a lot of providers do that, pulling up beside. It's like metaphorically, it means so much. And again, that transparency, we talked a lot about, you know, those, I think it was, oh, I can't remember who it was talking about the treatment agreement guidelines, right? The transparency, again, of what's going to be happening. Next slide. What we do physically with our body is so important. Maybe even just noticing if your hands are sort of tense, that you can literally release your hands, right? And softening your jaw. These are all things that put you more into that parasympathetic response. Deepening your breath, leaning in to the discomfort. And this idea we're learning so much about mirror neurons, right? So what's happening when we walk in that room? Are we trying to get out as fast as we can? Are we talking really fast? Versus, you know, can we come in and really like deliberately sort of put ourselves in a little bit more of a relaxed response can go a long way. Michelle, next slide.
Next slide. And identifying with your patient that doing new things such as movement and tapering will likely feel uncomfortable, but reminding them that hurting does not equal harm. You know, giving them, again, going back to expected, you know, realistic expectations, but this goes along with that of, you know, that there is going to be some uncomfortableness, and what does that look like? And also applauding them for the wonderful things that they have been doing, that Sharon walked to the mailbox, that is an accomplishment in itself. So, you know, making that balance of, I'm going to ask you to do something, but I'm going to reward you for, you know, doing something also, you know, making that, you know, the kind of partnership actually with your patients, identifying all those things with your patients. Next slide.
Michelle, I just want to say one thing before you go into this. I'm just really loving the chat box, and wanted to just comment on a couple of things. I love this idea about when there's some non-compliance, say around a UDS, where how we go into a room and say, you know, can you tell me more about this, versus like, whoa, there's, you know, sort of hitting somebody with the results, right? Help me understand it better. It's beautiful. Validating emotions, right? And I love the term VEMA, which stands for validate, educate, motivate, and activate. And I would just say, if you're having a struggle with a patient, always go back to validate. always go back to validate. And validating does not mean you agree with the behavior that is going on with the patient, and to remember that. And sometimes that's hard to remember. So I love that, is using motivational interviewing. And this thing that Paul writes in there about, if you have more than one person in your clinic, which most people do, then you yourself can have an opioid review committee. And honestly, I was working with a clinic, and I would say, well, how does this work in your clinic? There's literally just two, the provider, the MA, and who was also the front desk person, and they would like go into the back room and have the conversation, and they would call it their opioid review committee, and then they would be able to come back and share that with the patient. It's just getting a little bit of separation, and then being able to come back and say, I've reviewed it with the committee. And somebody was saying that earlier, it's like using the team feels this way, the team feels that way. It's going to be so powerful in having these conversations. Okay, Michelle, I think we're in our home stretch, and I know we're coming at the end of our time here. So
we are at our home stretch, and I wanted to say one more thing too. In our resources, we're going to talk about our VIMA cards too. So we have a specific pocket card that has the VIMA model on it. So we'll talk about that in the resources in just a second. Going back to our pain map and how all pain is legitimate. It is uncomfortable, the patient and the family, looking at this pain map, it is uncomfortable for everyone in the situation. But again, it goes back to that willingness to be uncomfortable. Our last component is really the most important component, because if we were willing to be uncomfortable, none of us would be in the opioid or pain crisis. That's how we got here, is because we weren't willing to be uncomfortable. We wanted pain medication to solve the problem. The provider wanted to help, of course, the patients, and the patients just wanted to not be in pain. So really, it's this, willingness to be uncomfortable for the provider and for the patient. So next slide.
Sorry, I'm just having so much fun in the chat. Nora now she has 20 points. I don't know. I'm gonna have to send her some of my brother-in-law's home brewed coffee or something. I don't know. She's really knocking it out of the park. Dan Claw, yeah, from University of Wisconsin. No, I can't remember. She'll tell us, or Paul will, I'll bet.
Yeah, and I'll just say, Michelle and Laura, I know you've got great information, and so if there's any way to sort of come to a place of pause here in the next minute or two, just because we do want to continue to be as on time as possible.
Yeah, this is it. I mean, because everybody's going to get the slide deck, and all the resources that we mentioned are in the slide deck. So really, we've wrapped up, and we're just so appreciative to be here. And Michelle, I don't know if you have any closing.
No closing statements. Thank you so much. Yes, please go to our resources. We have all these great resources for you, and we want you to use them. And we're so happy. And we're so happy to be able to work with all of you. This has been a wonderful experience, and it went off without a hitch from what I've seen on the virtual platform. So congratulations.
Love the platform. Yeah.
Yeah.
Yeah.